start with a brief introduction. Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. It's a distinct pleasure to have Dr. Maryam Khan give us a lecture on rare and a focused disorder, management of paroxysmal nocturnal hemoglobinuria. And Dr. Khan is working as a consultant clinical hematologist and transplant physician at Armed Forces Bone Marrow Transplant Center. And her area of interest include bone marrow failure syndromes. And I know that bone marrow failure syndromes is a challenge to diagnose, manage in underdeveloped countries, in outside North America. The expertise required to manage these patients are very limited. So with that background, I will have Dr. Maryam start her presentation, please. Thank you.
Thank you very much. I'll just switch over to my slides.
Dr. Maryam, we can see your slide.
You can see my slides. Perfect.
Yes, please put on slide.
Perfect, I will. Assalamu alaikum. I'm Dr. Maryam Khan. I'm a consultant clinical hematologist, as Dr. Faiz has kindly introduced me. So the topic would be management of PNH or paroxysmal nocturnal hemoglobinuria in both resource-rich and resource-constrained settings. So this shall be the sequence of my presentation. And can you still see the slides? I'm not sure.
Yes, we can see the slides.
Right. Okay, perfect. So, what is PNH? It's a rare acquired clonal hematopoietic stem cell disorder, which is characterized by complement-mediated intravascular hemolysis. And the main features include thrombosis and bone marrow failure. So, PNH, it's a rare disorder, as we've already talked about it, but its global prevalence is around 15 or 16 million individuals, and the annual global incidence is around 5 to 6 individuals per 1 million people. Now, that's a very, very crude estimate, and the actual estimate is supposed to be higher than this because of the reasons that we will talk later, including atypical presentations and delayed diagnosis. So in order to counter this underrepresentation and underreporting of this disorder, the Global PNH Registry was established with the sole aim, and it is a patient-driven, and it is open to patient reporting as well, so as to have a correct estimate of the incidence of this disorder. So if the incidence increases, but it can occur at all age groups. It's less seen in the pediatric age groups. The median onset is around 40 years. It is seen equally in men and females, some studies suggesting a slightly higher incidence in the females. And the incidence and the prevalence, again, in the US is roughly the same, and the incidence is also the same. The important thing is, why is it important to diagnose it, and why is it important to accurately report it? Because 35% of the PNH patients lose their lives within 5 years from diagnosis. And the major cause of mortality in this patient subset is thrombosis. And as we will talk later, the diagnostic delays play a major role in these delays. So what is the pathogenesis? We need to know that it is an acquired hemolytic anemia, which is caused by the mutation of the PIG-A gene. So the PIG-A gene is responsible for making the GPI, or the glycophosphatidylcholine inositol anchor proteins. These anchor proteins are present on all hematopoietic cells, and these are necessary for binding of CD55, 59, and many more anchor proteins as well. So these anchor proteins perform a variety of roles. However, the most important role or function that we see when they lose their position on the hematopoietic stem cells is they become particularly susceptible to complement-mediated hemolysis. It is a non-malignant clonal hematopoietic disorder, and there are two main pathogenics. Number one is there has to be an big A gene mutation. This is an X-linked gene mutation, and then the mutation it needs to expand as well. So most of the times the mechanism of expansion is the expansion of mutant clone because of the survival advantage. Because what happens is, because when there is a T cell mediated immune attack, the attacks are usually the proteins which are anchored by the glycoprotein anchors. So what happens is in PNH patients with PNH clone or those harboring these clones, because of the non-expression of these proteins, they usually escape the immune attack, and this leads to relative survival advantage. So clonal expansion and acquiring other additional mutations is a role, but that can also be a mechanism, but that does not contribute to the majority of the cases of PNH. So it's only seen in a small subset. So what are the things that favor the immune escape model? Number one, the most important association of PNH is aplastic anemia. So in aplastic anemia, we have an immune mediated attack, which leads to the apoptosis and death of the normal hematopoietic precursors. However, those who are not expressing the anchor proteins, they survive. And even there are patients or people who have microclones, but they do not expand without a selective environment. And again, if there is a syngeneic bone marrow transplant, unless there is an immunosuppressive conditioning which is given to the patient, this clone alone is unable to sustain and to produce the whole phenotype of the disease. And there are, in the mouse model, what happened is, because when the genes were inactivated, so in situ blood cells that do appear, the clones, PNH clones do appear, but they tend to disappear with time. So the mutation alone is not enough. It has to be supported by the immune attack model. Now, this again is the same. I'm just mutation genes are not sufficient for clonal expansion. They lead to survival advantage. And very importantly, PNH is not associated with inherited bone marrow failure syndromes, particularly in our part of the world where consanguinity is endemic, and it is very hard to distinguish acquired aplastic anemia from inherited bone marrow failure syndromes, even in young adults. So if you find a PNH clone, albeit small, it can effectively, efficiently, confidently rule out inherited bone marrow failure syndrome. So this is the mechanism of hemolysis. As we know, this is the complement pathway, which is always working in our body. So alternate complement pathway, it is always at play in the body. And there is a physiological, that's called a physiological C3 takeover, like C3 is always formed in the body. But and then it becomes C3 and C3b, and then C3b becomes binds with C5b, and then they form membrane attack complex or MAC with the later complement proteins like C6 to C9. And what happens is, because when CD55 and 59 are expressed, so this membrane attack complex, it is neutralized. But in their absence, this membrane attack complex leads to intravascular lysis of these red blood cells. So what happens with intravascular lysis? It results in anemia. It results in thrombosis as well. So thrombosis, which is seen in 40% of the patients. So this is a basic diagram of what happens. So free hemoglobin release, it can activate the platelets. It can lead to fibrin clot stabilization as well. And it can lead to endothelial activation. It can lead to neutrophil activation relating to netosis and all that stuff. So this is a very prothrombotic milieu that is created in the patients with PNH. And they can present with thrombosis of all sites, and particularly atypical sites. So atypical site thrombosis is very, very commonly seen in PNH, and is often a clue to the diagnosis. So any patient who presents with features of aplastic anemia and thrombosis should always alert us to check for PNH. So this is a tetrad: intravascular hemolysis, thrombosis, smooth muscle dystonias because of free nitrous oxide that is released. So many patients would present with abdominal pains, esophageal spasms, and unexplained pains, and often referrals to psychiatry, unfortunately, wards as well. So what the essential diagnostic criteria: number one, we need to see the patient from the CBC. The patient is hemolyzing. Anemia is the most common presentation. LDH would be raised, indirect hyperbilirubinemia would be there, and hemoglobin would be low, all pointing towards hemolysis. And this needs to be further tested with to rule out the absence of glycoprotein anchor proteins, and bone marrow biopsy and cytogenetics to rule out if PNH is classic or it has evolved. So this is the classification of PNH. So classic PNH is the most common presentation, which is seen in 70 to 80% of patients, and it presents with features of hemolysis. And usually the PNH clone that we see in these patients is huge, it's large, and it's more than 50%. That would give such a presentation. And other presentations would be PNH in the context of bone marrow failure. So a patient who presents with pancytopenia, otherwise diagnosed as aplastic anemia or MDS, and you find a small clone in it. So this would be PNH in context of bone marrow failure. Now, bone marrow failure can have a small PNH clone, or PNH could be in the context of bone marrow failure as well. These are confusing disorders. So some explanation could be if a patient with bone marrow failure syndrome would have retic count like 2%, 3%, a slightly raised retic count, slightly raised LDH, should always prompt us to investigate for PNH in the context of bone marrow failure syndrome. Now, why is this distinction important? Because even these patients are prone to thrombosis, and if they are taken to bone marrow transplant, which eventually is the most is the curative disorder in most of these patients, so they would require some sort of complement inhibition or maybe anticoagulation during the conditioning phase as well. And subclinical PNH is just usually with bone marrow failure syndrome, if you usually find a small clone, the importance is it can effectively exclude inherited bone marrow failures, and it can sometimes predict response to the immunosuppressive therapy as well. So this disorder can progress in approximately 2 to 6% of the patients, longer disease durations, acquiring additional mutations, and telomere attrition are known to be factors contributing to this progression. Again, PNH it is a non-malignant disorder, but it severely affects the quality of life. It results in severe fatigue, markedly reduced quality of life. Patients, they have serious issues with their employments, and even the thing is even in CF5 or inhibitor eculizumab or patients who are treated with complement inhibitors, the fatigue is still a major part and parcel of their life, and results in daily activity impairment in most of the patients. So now this is really concerning, that if this disorder is often diagnosed with a significant delay, and many patients see 2, 3, 4 physicians before they actually receive a diagnosis. And unfortunately, 40% of the patients develop a thrombotic events prior to diagnosis, which is often debilitating and can have significant morbidity and mortality as well. So why is this important? This background is important because we need to act smart, and we need to screen for this disorder more, so that patients can be identified early and should be offered treatment earlier to avoid all these complications. So any patient who presents with unexplained hemoglobinuria, with intravascular hemolysis, or hemolysis with iron deficiency anemia, or even in patients with unexplained iron deficiency anemia, patients with thrombosis involving unusual sites. PNH causes thrombosis at arterial sites, venous sites, and microvasculature. So all these sites, but particularly the most common presentation is Budd-Chiari syndrome. Patients with aplastic anemia, we need to screen for the clones as well in patients with MDS. So it's very important sometimes in patients to distinguish for patients from aplastic anemia with hypoplastic MDS. So there was a paper in Blood which clearly showed that aplastic anemia in MDS, so if there's a small clone present, this clearly favors aplastic anemia in support of hypoplastic MDS. However, patients who have evolved from aplastic anemia to MDS would retain this clone. So, and again, patients with explodic dysphagia or abdominal pain that is otherwise unexplained. For patients who have an unexplained thrombosis, so if there is an evidence of thrombosis, of the site is atypical, and the patient does not have typical risk factors for thrombosis, then again, this is an indication of testing by FLAIR, which I will talk about in the next few slides. So detection of PNH clone, now we know what are the usual presentations and who to screen for, and which are the type of patients that we need to screen, and what are the methods that are available. So complement-based testing was the initial test. But it is obsolete now because it's pretty crude and it has high rates of false positive. Even patients with megaloblastic anemia and autoimmune hemolytic anemia can be falsely tested in using this assay. So it's actually obsolete now. Diagnosis of PNH by flow cytometry, it is pretty much in vogue in the low middle income countries as well. So what happens is the flow cytometry targets the glycoprotein and anchor proteins, the antigens, particularly CD55 and CD59. So their absence would indicate the presence of a PNH clone. So it is not very sensitive. So it usually detects 1%, mostly 2 to 5%. And there are high sensitivity analysis as well, which I will talk about, which is the FLAIR testing. So CD55, 59 testing is not as sophisticated, not as sensitive, but it is pretty useful in the low middle income countries. So it is the FLAIR testing, which is the fluorescent aerolizing fluorochrome conjugated molecule. Now it is the gold standard of testing for PNH clone. It not only assesses the presence, it assesses the size of the clone as well, which again correlates with clinical presentation and prognosis, and it delineates the type of the cells as well. So this is the types of red blood cells would be type 1, type 2, type 3. So type 3 cells would be those cells which are completely lacking the glycoprotein, anchor protein expression, and type 1 are those with a normal expression. So why is FLAIR important? Why? Because it does not target or assess a single protein which is expressed by but it actually is a marker to see the absence of the glycoprotein anchor itself. So it tests the anchor and not the protein expressed by it. So that's why, because there are certain inherited disorders which can also cause deficiency of CD55, 59, or certain acquired disorder, which can lead to underexpression of these antigens. So because FLAIR will target the anchor, so it is very sensitive and it is very specific. And it is usually done in a single tube. So again, the same, it is non-lytic aerolizing. Now FLAIR, what happens is it combines flow cytometry in it. So what happens is it will bind to the glycoprotein anchor and it will not lyse the cell, and then flow cytometry will detect those population which will lack this glycoprotein anchor. So it is the negative or the loss of expression in a flow cytometry or assay which will indicate or which will show that this patient has a PNH clone. So FLAIR, what happens is PNH cells, the FLAIR, it can detect the glycoprotein anchor deficiency on the granulocytes and the monocytes, because but there are reasons which are not very clear why it does so, but it does not effectively bind the red blood cells. So if we want to see the red blood cells, whether they express or lack the glycoprotein anchor proteins, so testing for CD55, 59, or 235A has to be done in a separate tube and tested by flow cytometry. So lack of FLAIR binding to granulocytes is sufficient for diagnosis. So for flow cytometry, we need to see the deficiency in at least 2 lineages. But for FLAIR, if we see FLAIR negative granulocytes, lack of binding of FLAIR to granulocytes, this is sufficient for diagnosis. And again, many times we receive calls, what kind of sample needs to be sent for PNH testing. So it has to be a peripheral blood sample, because sometimes in bone marrow samples, there is a natural lack of glycoprotein anchor protein. So bone marrow is not a good sample for PNH testing. It has to be tested on the peripheral blood. And again, in patients with MDS, there is sometimes loss of anchor protein, loss of the surface protein. So the diagnosis can be sometimes missed if there's a small PNH clone. So this also needs to be kept in mind when testing. So again, this is a table-wise comparison, because FLAIR would bind directly to the anchor protein. It sees the granulocytes and monocytes. It is highly sensitive, highly specific. However, the cost and expertise vary. So now in Pakistan, all major labs are offering FLAIR. So it is pretty much becoming the standard of care, because CD55, 59, the most common the disadvantage with this is because in transfused patients, if we see, if we are testing on red blood cells only, so this will test the transfused red cells and we will have false negative results. So now the best approach is because FLAIR will not test RBC, so it's usually done in two tubes. So FLAIR testing for glycoprotein anchor in one tube, and CD55, 59 and testing by flow cytometry on another tube. So these are complementary, and this is the current best practice which is recommended by most diagnostic guidelines. Just diagnosing them once is not enough. We have to follow them as well. So if once seen, we have to follow them 6 monthly and then yearly if it's stable, to see if there is any progression. Because if there is progression, there is again risk of complications, and there may be this may be a rationale for treating with the directed therapy or complement inhibitor in this case. So again, in patients with aplastic and MDS, we also need to see them at diagnosis, and we need to see them after 6 months initially, and then later as well, and more frequently if there is a clinical deterioration or evidence of hemolysis. So this is the typical bone marrow examination in classic PNH. So we can see florid erythroid hyperplasia, and that is seen in a hypercellular marrow. Sometimes if it's associated with MDS, we can see the dysplastic changes as well. So these are the flow scatter plots that we usually see. So what is in the top plots, there is the gating done. So CD15 positive grands are separated, and then we see the expression of CD24 and FLAIR binding on the granulocytes. So it is the lower left corner. It is the double negative quadrant, basically. So these are the granulocytes which lack both FLAIR binding and CD24, which is a glycoprotein anchor protein bind. So both of these are not bound. So this is a double negative population, and this is a huge clone. So this is 97% of all granulocytes. So this is what the flow plots look like. So again, this is the monocyte. The gating is done using CD64, and we can see that CD14 and FLAIR both are negative. So this is a double negative compartment. So again, monocytes are also negative. So this is the flow plots for red blood cells. So red blood cells, we do not test them with FLAIR. So we either test them for CD55, 59, or 235A. And it can, as we see, that it has separated into 3 compartments. So type 1 with normal expression, type 2 with moderate expression, and type 3 who have negative expression of CD55 and 59. And these are the cells that are responsible for the hemolysis. So if the type 3 cells are actually contributing to the hemolysis and thrombosis. So what is the management? These are the basic management steps. So it has to be supportive. Folate is very important in all cases of hemolysis. There is an increased red cell turnover, and patients are frequently folate deficient. Folate supplementation is absolutely essential. Iron supplementation is also essential because this is intravascular hemolysis, and there is frequent iron deficiency associated, and transfusions with the typical thresholds below 7 or as per patient symptoms, and anticoagulation in patients, particularly in high-risk situation. So complement inhibition is the mainstay of treatment, and it has evolved over time, and it has long, huge safety data as well. Psychosocial support, again, because of fatigues and poor quality of life, and again, the challenge of breakthrough hemolysis, like this means hemolysis despite complement inhibition remains. So those patients who have bone marrow failure in PNH in context of bone marrow failure, so the treatment would be directed at the bone marrow failure rather than PNH itself. So if PNH is in the context of aplastic anemia, the treatment should be directed at aplastic anemia rather than PNH. However, the clone is significant, we can consider complement inhibition as well to avoid thrombosis and other complications of PNH. Corticosteroids still very frequently used in our part of the world to reduce transfusion requirement, but its use is controversial, and obviously steroids, as we all know, have a hassle of side effects. And aggressive infection control, because we must all go back to the complement cascade, because it is the complement or the lectin pathway, which is alternate complement pathway, which is the tick over, which is causing all this hemolysis. So anything that aggravates the complement pathway is going to lead to worsening of in hemolysis and the features of PNH. So all these needs to be addressed. So this is a table. So number one, we just showing the management of PNH, whatever we have discussed previously. So subclinical PNH, we don't need to do anything. So if it's a classic PNH, it needs to be treated with eculizumab or the C5 inhibitor, whatever is available or approved in those settings, in your settings. If there's a good response, fair enough. If it's not, we can try to increase the dose, maybe add in other complement inhibitors, or maybe move on to bone marrow transplant. And if it's PNH in context of other disease, we need to focus on the other disease. So not all patients with PNH need treatment. So all those patients with severe anemia, like anemia which is bothering their quality of life, patients with thrombosis, patients who have symptoms or renal insufficiency, these are pretty hard indications. So we have other soft indications as well. You don't need to, I would primarily assess a patient and see if the patient doesn't necessarily need to have a severe anemia. Sometimes a patient with a good hemoglobin, but quality of life would be impaired, then PNH-directed therapy would be required. And because we know that these diseases are progressive and sometimes the clone tends to get worse, so it is probably wise and early to start the treatment earlier to avoid the complications associated with it, because many of the complications, including renal disease, thrombosis, they are not reversible. So these are the targets of therapies in PNH. So we have come a long way in PNH. So this is again, we're talking of advanced countries where all these therapies, complement inhibitors, are available. As we can see, this is the alternate pathway which is causing most of the symptoms, most of the features, and the cells are unable to protect against them. So the initial targets was the C5. So by blocking C5, the membrane attack complex was abolished, it was stopped. And because the membrane attack complex is basically the mediator of intravascular hemolysis, so this led to significant improvement in hemolysis and fatigue and quality of life. But as we can see, the C3b remains in this. So C3b can cause coating and extravascular hemolysis. So this led to the idea of why not we have a proximal complement inhibitors. So then came the proximal complement inhibitors, which not only led to reduction in the intravascular, but also the extravascular hemolysis as well. So we have pegcetacoplan, iptacopan, danicopan, and the vemirocopan as well. So eculizumab, it was the breakthrough treatment. It was the first C5 antibody, monoclonal antibody, which received FDA approval in 2007. It not only led to clinically significant reduction in hemolysis, but improved the significantly decreased transfusion needs and HP level and fatigue itself. It lowered the thromboembolism rate, and it has led to high survival rates, 73 to 98% in favorable renal outcomes. And along with the drug has long-term safety data, it is pretty well tolerated. And there are a few adverse effects, which we will discuss in the later slides. So these are the phase 3 trial RCT Triumph, which was a double-blind placebo versus placebo trial, which led to these were the trials that led to its approval. So transfusion independence was seen in 51% versus 0% patients in the eculizumab arm, and significant fatigue and quality of life improvement. And again, this was by Hillman et al., published in the New England Journal of Medicine. 52 patients, eculizumab only arm, so there was no comparison arm. So this led to a reduction of 87% in LDH. So why is LDH important? Because we know that it is a marker of hemolysis, and LDH improvement can actually lead to symptom improvement and signs and complications reduction in PNH. 51 achieved transfusion independence, and fatigue stroke significantly improved as well. And then we have the long-term data as well. So 3-year survival, 97.6%. And as we know, the transfusion independent and LDH decrease has persisted for 2 years, and now we have 3 and 5 years data as well. So this again is international PNH registry, non-transfused patients as well. It has been used in the non-transfused patients as well. Real world data, systematic review, all in favor of eculizumab. Significant reduction in LDH, major arteriovascular events, transfusion requirements reduction, and with mild adverse effects, including headaches. But there's the major significant adverse effect that we see with this is the serial infection. So by binding to the complement proteins, by inhibiting them, we would know that this is going to bind C5, which is going to impair the membrane attack complex. And this is what we want, because we don't want the membrane attack complex hemolyzing the cells. But what happens is it is an essential requirement for defense against the Neisseria species. So we found there was 1,000 to 2,000 times increase in the risk of Neisseria infections as compared to general population in these patients. Now, as we see, the highest risk is in the first few weeks, but the risk never really goes away. And as we know, this Neisseria meningitis is a life-threatening infection, so we need to be very, very cautious about it. And this needs to be, whenever a patient is started on complement inhibitor, this needs to be discussed with the patient, and they need to be informed of the risk. It's important to give them information leaflets, maybe give them a bracelet or something to indicate that these patients are at risk of these serious infections as well. Now, at least 2 weeks prior to starting treatment, vaccination is very, very important. And many patients would still require antimicrobial prophylaxis, especially if these patients are in areas where these infections are very risky, or maybe they are traveling for Hajj, or we should strongly consider antimicrobial prophylaxis during those settings as well. Patient education and information provision to the primary healthcare providers is very, very important, and urgent treatment for any suspected infection is also very important. So whenever a patient is on eculizumab, we need to monitor them as well, as to see if the patient, if the drug is actually working or not, because now, fortunately, we have a plethora of new drugs coming up. So the hemolytic profile, which includes CBC, LDH, retics, and indirect hyperbilirubin, they need to be evaluated monthly in the first 3 months, and then 3 monthly. This can be tailored as per patient presentation or your own resources as well. Again, iron studies, very, very important, because the iron deficiency is very common in this subset, and sometimes replacing iron would lead to reduction in fatigue and quality of life and transfusion requirement, and this is very important. And transfusion history needs to be monitored as well, just to see if their patients are actually responding or not. And again, the hematinic replacement alongside needs to be done, and PNH clone analysis. Now we know that the eculizumab, it does not have a disease-modifying role, so it will not act at the level of the PNH clone, or it will not act at the level of the genes. So the clone needs to be assessed, because sometimes with the clone becomes bigger, the problems become bigger as well. So you maybe need to modify your doses or drugs according to that. And bone marrow examination, maybe 2 years. Sometimes you would need as well, because there's a risk of progression of PNH to MDS and even acute myeloid leukemia. So that needs to be borne in mind. Bone marrow examination, careful peripheral film examinations are very, very important as well. Now, the problem with C5 inhibitor eculizumab was it needs to be given weekly in the initial induction phase, and then twice weekly. And it's a parenteral administration. So many people found it cumbersome because it's a lifelong treatment, and having to get an injection very frequently. Sometimes it's not very liked by the patient. So there was this drive to get better and C5 inhibitors or complement inhibitors that are more patient friendly. So this is a long-acting ravulizumab. It's a long-acting monoclonal C5 monoclonal antibody, and it has a half-life of 8 weeks. So it would require a weight-based loading dose, and then the maintenance would be 8 weeks. So there would be an injection-free or infusion-free interval of 8 weeks approximate. And there are trials to show eculizumab, its non-inferiority to eculizumab, and ravulizumab has fared pretty well and has shown consistent non-inferiority in eculizumab in both complement inhibitor naive and experienced patients. And again, very understandably, longer duration interval improve convenience and compliance. So that's something that we achieve. So 301 and 303 trials were the basis or rationale of approval of revolutimab. It were both phase 3 randomized, open label, non-inferiority trials. And the 301 enrolled patients who were C5 inhibitor naive, and 302 who were already stable on eculizumab. And it was a 26 weeks one-to-one randomization, and primary evaluation was at the 26 weeks. And then there was extension where all patients were shifted to revolutimab. So 301 up to 5 years data, 302 up to 3 years data. So again, we see the CRO primary transfusion avoidance was almost the same, and LDH normalization the same in both. So non-inferiority again in the fatigue scores, the HP stabilization scores, and however, the breakthrough hemolysis was slightly better in the revolutimab. So the breakthrough hemolysis was only 4% in the revolutimab and 10.7 in the eculizumab arm. The adverse effect profile again was pretty safe, and the headaches were the most common adverse effects, and there were no meningococcal infection. There was only one leptospira infection in the revolutimab arm. And a 302 study was again a non-inferiority study, and the patients who were not only treated with eculizumab, there were patients who were stable on eculizumab. So again, by shifting to revolutimab, the LDH maintenance was maintained. And breakthrough hemolysis, again, in the 302 study, it slightly favored revolutimab arm. Transfusion avoidance was same in the both arms, and headache again was the most common adverse effect in this. So this is the data from the long-term safety and efficacy. So it's not very clear, but as we can see that the figure on the top is the figure A. It is the 301 study, and the B is the 302 study. As we can see, with both in the revolutimab to revolutimab arm and in the eculizumab in the revolutimab arm. So the change in LDH is the same. It has not risen. It's pretty stable and is static in the long term as well. So with the LDH reduction is maintained in both the revolutimab arm, and it has maintained in the long term as well. So that's pretty reassuring. So again, this is about the 302 study as well. As we see, the breakthrough hemolysis is slightly improved in the revolutimab arm, and transfusion avoidance and hemoglobin stabilization is pretty much the same in both. So again, as we discussed, eculizumab and revolutimab. So now there was a talk of maybe getting more agents because of the problems with parenteral administration, because of the problems with breakthrough hemolysis, which is a major issue with C5 inhibition, because by inhibiting C5, C3 is still there. It's going to coat the red cells, and these cells are going to be hemolyzed by the spleen. So what happened was there was a shift to terminal complement inhibitors. Alternate complement inhibitors, and with better routes of administration, including not only subcut with pegcetacoplan, but also orals as well. So danicopan and iptacopan are the oral complement inhibitors, which target the distal proximal complement C3. And iptacopan is a monotherapy, and danicopan is an add-on therapy. So as we see in this table as well, so eculizumab, it blocks the C5 and prevents MAC. It is IV, it needs to be administered every 2 weeks. Revolutimab is C5, it is a long-acting drug, and its route is IV, and it needs to be given every 8 weeks. So that's the advantage. Crovalimab is C5, it is subcutaneous, hence the ease of administration, and it is given monthly. So pegcetacoplan is proximal complement inhibitor, binds the C3, prevents opsonization by C3b and terminal activation, and it is again subcut, and it is given bi-weekly. So iptacopan, it is oral, it inhibits the factor B. So in the complement cascade, if I'll go back to the complement cascade, so before C3, there comes factor B and factor D. So by activation of factor B, C3 is activated, and C3b and the big B, they bind together, and then they go on and activate the rest of the complement pathway. So iptacopan pretty much targets the complement pathway higher up, even more proximal to the C3. So it does not give the substrate to C3. So there is there's very little opsonization, and there is very little room for extravascular hemolysis as well. So, and the advantage, this is all done to reduce the intravascular hemolysis. It's oral, it's twice daily. Danicopan, it's an add-on because of the extravascular hemolysis, and then we have these novel agents as well. So again, these are the novel agents. As we can see with iptacopan, is around 3.2 gram per deciliter improvement in HB, and these are the approvals as well. So pegacetacoplan was approved in the PRINCE study and the Pegasus study. Both showed improvement in HB and transfusion requirement as well. And the adverse effects were pretty manageable, with most patients having diarrhea as well, and it led to improvement as well. So crovalimab is again monthly C5 inhibitor. So it's just a once a month subcut administration, and because of its ease of administration, it was preferred by 85% of patients in the trial and in the real world as well. So it was proved in the Commodore 1 and the Commodore 2 non-inferiority trials. So all the parameters were pretty much the same, but patient preference because of ease of administration. So this is a visual summary of the Commodore 2 trial. Again, patients were offered crovalimab or eculizumab, and then they were either allowed to continue in the initial phase, the primary phase, and then with eculizumab were switched to crovalimab. And as we can see that crovalimab is non-inferior. So it was non-inferior in hemolysis control, transfusion avoidance, breakthrough hemolysis, and hemoglobin stabilization as well, and improvement in fatigue also. And as we can see, that 84% of patients prefer crovalimab, mainly because of ease of administration. So oral iptacopan, as we discussed, is a factor B inhibitor. So it acts higher up, it is oral, and so hence the ease of administration. It was approved by 2 phase 3 trials, a huge database to support it, appoint PNH, apply PNH, tested in both complement inhibitor naive patients and those patients who had actually had residual anemia despite eculizumab. Now, this is a pretty tough population. So these patients would have troublesome anemia despite eculizumab and nivolumab as well. So when we switched to oral iptacopan, and so in 82.3% of the patients, there was more than 2 gram improvement in HB in these patients, and it is fairly well tolerated as well. So this is a visual description of both these in the initial preliminary phase and in the extension phase as well. So iptacopan led to 82.3% improvement in rise in HB more than 2. And again, all of these were transfusion independence, 8B change, fatigue scores, all of these, there is a significant improvement in comparison to anti-C5. That's a plus in addition to the oral administration. Now, safety profile again was very safe, and there were no major signals that were seen in the trials. Danicopan, it's a factor D inhibitor. It was tested initially in a phase 2 study, and then in the phase 3. So it was an add-on to C5 inhibitor, oral add-on for those patients who were having significant extravascular hemolysis because of C3b. So the trial was for those patients who were already on the C5 inhibitors for more than 6 months. As we see that there was a clinically significant change in hemoglobin, and again, a transfusion avoidance and fatigue, and there was a durability of the improvement in HB at the long term as well. Again, the safety profile seems to be very good as well. These are the summary of the clinical trials that I've already talked about. So breakthrough hemolysis, we have talked about it. I'm going to talk about it more again because this is a challenge. It occurs with all complement inhibitors, more with the C5, less with the C3. Why it happens? Because sometimes this is a diagram I'm actually running short of time, so I'll just focus on this table. So it can be pharmacokinetic or pharmacodynamic. As we know, pharmacokinetic would be when the drug is not doing enough. So we need to probably increase the dose. And pharmacodynamic, maybe the complement pathway is too overwhelming, or maybe the drug is not bound, or because of certain polymorphisms, it's not doing very well. So with pharmacokinetics, usually there is intravascular hemolysis. With pharmacodynamic, usually there is extravascular hemolysis. So whatever we have, breakthrough hemolysis, there's a recent article that was published in Blood. So if it's clinically significant, number one, we have to define if it's clinically significant, if it's causing significant drop in HB signs and symptoms and raised LDH. So there has to be we have to offer these patients support in the form of transfusions as well, and we have to assess the cause of breakthrough hemolysis. So if the patient is in the complement inhibitor, a terminal complement inhibitor like C5 inhibitor, eculizumab or reviluzumab, we need to bring the dose in earlier. So probably the dosing frequency needs to be increased. Or if the patient is if the patient is on pegacetocoplan, we need to increase the dose or increase in frequency. Or if the patient still has this, despite of all this, or then we need to probably switch the patient to earlier complement inhibitors, C3 blockers, or maybe with danicopan coming in, we can add on danicopan to the C5 inhibitors. So that's where the problem is, and BTH is becoming a major issue in the management of landscapes of PNH. We don't have these fancy drugs and those really working drugs in our part of the world because of the huge costs these are the estimates that I've mentioned. So we transplant these patients. Patients do receive corticosteroids. They receive transfusions, many of which are not very good quality, severe diagnostic delays, non-availability of flare testing, and false negative results because of flow cytometry and a few challenges that we see in this. So transplant outcomes, there's not a lot of data, but it has been done, particularly before in the pre-complement inhibitor area and worldwide as well. So it's a pretty decent overall survival, 1 year overall survival rate, 80 to 90%, and 70 to 90% in the 3 to 5 year. And as we see, the acute GVHD and the graft failure is pretty decent as well. We see the overall survival is 3 to 5 is 70 to 9%, and transfusion independence is seen in most of the patients who survive. So matched sibling donor has the highest survival amongst all donor types, followed by MUD and then haplo transplant with BT side. So as per conditioning, RIC seems with serotherapy with either limtuzumab or ATG, it is associated with the best outcomes with lower GVHD, non-relapse mortality, with adequate disease control. So because of these patients are transfused, there's an increased risk of veno-occlusive disease, particularly with myeloablative condition. There's no clear OS advantage. And if the complement inhibitors are available, they probably should be used in the peri-transplant period as well. So again, matched sibling donor, highest overall survival. And so these are the studies that we could find. ABMT has shown that there's now this ABMT 2020 data is available in the oral abstract form only. So we don't have a very good estimate, but this seems to have improved the survival from 68 to 85%. Fludarabine-based RIC appears to do best. RIC and the Poland cohort, they have shown a survival of around 94% in classic PNH. And again, the CIBMTR, 70 to 80% in the current times. And treosulfan fludarabine also appear to be a quite logical conditioning. This is our data from the PBMT 2008 to 25. So it's 28 patients and median age is 24. It's young patient population, all males, all HLA matched sibling donor, and the conditioning was myeloablative in the classic PNH, and this is overall survival of 89.3% and disease-free survival of 85% at 39 months. These are the survival curves. So thank you. So I'm open to questions if there are any.
Yep. Thank you, Dr. Khan. This was fantastic presentation. Let me see if we can look into the questions and answers. There was one question. It's under the webinar chat. What are the plausible reasons for the Coombs positivity in diagnosed case of PNH? Have you come across a case with Coombs positivity and PNH before?
So yes, that's a very good question. And Coombs positivity, we do tend to see Coombs positivity in patients with PNH as well. And that's one of the reasons that people, when they see hemolysis with Coombs positive, they don't even, they tend to exclude PNH. So so Coombs is a very a tricky test. So if we, those people who have some degree of training in the laboratory or some understanding of the test, so we need to know that the Coombs test is actually seen by the degree of agglutination. So there are various, stages and degrees of Coombs positivity. So one positive Coombs, which we all often see, which is a microscopic positivity, which usually is not very significant clinically, that can be present in not only PNH, but many other conditions as well. And another common cause of Coombs positivity in these patients would be transfusion, which is the most of the case. Because with Coombs positivity, the most common cause of Coombs positivity in any patient would be earlier transfusion in these patients. So whenever we are seeing a Coombs positivity, we need to see if it's a true positivity or if it's a false positivity. Again, we need to see what is the strength of Coombs positivity. If there are any other drugs that the patient has taken, for example, IVIG, for example, daratumumab, all those, anything that he has taken in that could probably result in this false Coombs positivity. If there's recent transfusion, if the Coombs is direct positive, indirect positive, and what are the types? And again, those patients who are treated with complement inhibitors, C5 inhibitors, they can have some degree of Coombs positivity because of C3 binding to the red blood cells. Now, that does not indicate these patients have Coombs positive hemolysis going on. Now, extravascular hemolysis would be Coombs positive, which is the breakthrough hemolysis that can happen in these patients, and which is a challenge that we have talked about.
Well, thank you for the detailed answer. There was another question I was posted, I think before you may have shown your slide where we using stem cell transplant. So question was, what possible treatment options do we have available in developing countries such as Pakistan?
So again, PNH, we need to be very clear. So if we are dealing with PNH, what is the type of PNH that we are dealing with? So 70% of the patients would have classic or hemolytic PNH. So unfortunately, we do not have complement inhibitors, even eculizumab available, which is the first drug which is approved for it. And even if it is available at some settings, the drug is not very reliable. It's not coming through the proper channel. So in low middle income countries, the first line treatment of patients with PNH is bone marrow transplant, unless the scenario changes and the complement inhibitors come in. Now, we do understand that bone marrow transplant is associated with significant mortality, morbidity, and with PNH transfused patients, particularly when we give them serotherapy, we often see brisk hemolysis occurring on the very next day. Various sensitivity to Sandimmune or cyclosporin in these patients, even severe hemolysis causing AKI, which we have seen in patients as well. So these are the challenges that we have.
I think on the similar lines, there's a question, how does one determine false versus true Coombs positive? So 2+ C3D in an untreated patient without having received transfusions for over 1 to 2 years.
Now, if that's the case, because then you need to maybe repeat the test, talk to your lab, maybe get it tested from a different lab. So the patient has not received a transfusion, has no other reason for Coombs false positivity. Sometimes we have patients with associated autoimmune disorders as well. So patients with systemic sclerosis, SLE, they would have that would have Coombs positivity as well. So if we do not have any of these reasons of false positive Coombs, patient is not on C5 inhibitors, patient is not transfused, it is a true autoimmune hemolysis, that this patient probably does not have PNH.
Okay,
So
great.
this is the diagnosis of Coombs. This is basically Coombs negative hemolytic anemia, acquired hemolytic anemia.
Well, I don't think I have any other pending questions, but we have roughly 6 minutes before the hour. I want to ask, because you've been involved seeing these patients who are being referred by the community physicians. So what mistakes are happening out there in the community, and what will be the message to correct the practice out there?
Yes, so the message would be number one, this is a rare disorder, but it is not as rare as we think it is. Many of the patients are missed. Most of the patients that we receive have had significant delays in diagnosis. So whenever a patient, the message to all the people who are working in community who are dealing with such kind of patients is whenever you see a patient who has cytopenias, who has hemolysis, maybe unexplained hemolysis, even unexplained iron deficiency anemia after years and years of workup, it is very, very important to refer these patients instead of giving them unnecessary trials of steroids, labeling them as Coombs negative autoimmune hemolytic anemia and whatever diagnosis that we have. It is very important to refer these patients to tertiary centers where there are facilities of flare testing available. Because unfortunately, we recently had a few examples where these patients were referred back to us by gastroenterologists because of unexplained anemias, undergoing colonoscopy, endoscopy, all the blood tests in the world, and then uh, referred for esophageal spasms and diagnosed as hiatus hernias, even being referred in the psychiatry wards. So it is very important for anyone who's had unexplained erectile dysfunction, unexplained anemia, unexplained renal dysfunctions. So this can present in a variety of fashions. And most of the times when the triad or the tetrad sets in, the patient is far too advanced to even receive a stem cell transplant. So it is very important to not just ignore that this is something that we don't see. If we don't screen patients, if we don't refer patients on the index of suspicions, we are never going to diagnose any of them. So that's very important. I hope if any one person just
No, this is a very good advice. We see in our practice some of the rare ways patients present or some of the rare diagnoses, they are mislabeled, misdiagnosed, and by the time we see them, they are very complex. I think on the similar line, there was a question, how can we ensure timely diagnosis of PNH in patients presenting with just iron deficiency anemia, particularly when hemolysis markers are stable, are masks, such as chronic low-grade hemolysis without overhemoglobinuria?
So that's a very interesting scenario, and that's the reason where many patients are missed. So what we do in our clinical practice is that whenever we have a patient who has unexplained iron deficiency and basic, so it's all starts from their history, as I would like be repeating myself. So if the patient has iron deficiency anemia, the diet is adequate, there are no problems with malabsorption, patient is not bleeding, and there's no obvious reason. So, and the basic workup is negative for iron deficiency anemia. There is absolutely no reason to refer this patient and get a flare testing done to exclude PNH as a treatable cause of iron deficiency anemia before the whole tetrad and before the whole clinical presentation sets in. So it's very important to exclude these things, exclude this diagnosis early on.
Well, that's wonderful. Thank you so much. I don't see any other question at this time. So you have last 2 minutes. Back to you. Message for the medical student, message for the community practitioners for any of the marrow failure syndromes you guys see in your practice.
So I'm very sorry, number one, I was very quick during my presentation. I think I may have been very quick. So well, the message would be like, number one, if we have a patient who presents with cytopenias could be a drop in blood counts, any of the blood counts. And it is very, very important to take a proper history. And it is very, very important to take a proper drug history because we often see these patients taking drug even and then it is important also to see have a good family history, because right now when we see bone marrow failure syndromes and we are doing genetic testing and we are taking family histories, so some of the patients would have long-standing history of thrombocytopenia and then evolving to aplastic anemia. So sometimes we have DDX1 mutations in these patients. And again, it is very important to see if there's any physical dysmorphism in them. You may be remarkably surprised to see hyperpigmentation, very subtle changes in the nails, and you find out these patients have dyskeratosis congenita. Patients being labeled as aplastic anemia, getting treatment with immunosuppression therapy for years and years because nobody bothered to take a look at their hands, and it was Fanconi anemia. So I'm not sure if it's very common in the Western world, but it's a very, very common scenario in our part of the world. Again, patients receiving a diagnosis of Coombs positive hemolytic anemia based on a single positive test, Coombs 1+, which could have been explained by like 100 things and labeled as autoimmune hemolytic anemia, receiving years and years of steroids, even undergoing splenectomy, all the treatments for it, and then one day having a stroke in their head and losing their lives. All those patients you see for Budd-Chiari syndrome, for unusual, even retinal vein thrombosis, clots in the upper limbs. You don't know where these clots are, especially the arterial clots. It's very important to exclude PNH because, again, treatments are very much available, and these are young patients where you can avoid all this. So we should not just push away these disorders thinking that they are rare and we're probably not going to see them. So.
Right. No, this is very helpful. Thank you so much. That I completely agree that it makes it is important. It's our duty to spend time with these patients and go through their history, do a detailed examination. If there's any doubt about the diagnosis, ask for help, go for a second review or testing. And if your treatment, which you started, is not working, go back and review your case and doubt your diagnosis. So, that's all to provide the best care for the patient. So I think it's the hour now. Once again, thank you so much. We'd love to have come back sometime and talk more in terms of additional marrow failure syndromes in the future as well. Thank you.
Thank you so much.
Allah Hafiz.
Allah Hafiz.